처음으로 이제 손영원 선생님하고 김태 선생님을 보시고 아르메니아를 갔다 왔습니다. 엔도스코피 연습 부분에서 사진을 좀 힘드셨어요. 좀 피곤하신데 이거 갖고 계셔가지고 힘들었고, 그다음에 손영 선생님이 병원에서 거기 아르메니아 병원에서 엔도스코피 연습하시면서 이제 수술하는 거 하셨던 사진이고요. 이건 김태호 선생님 사진이고요. 거기 그 닥터 릴리 보스코니안이라는 그 여자 선생님인데 그분이 수술 굉장히 많이 하셔가지고 제가 알기로는 1000케이스 넘게 하셨던 걸로 기억하고 있어요. 그분 옆에서 봐주시고 뭐 필요한 거 있으시면 도와주시고 그렇게 했었습니다. 네, 그거 끝나고 마지막 날 다 같이 이제 찍은 사진이고요. 이게 2016년도 벌써 7년 전 사진이에요. 네. 많이 젊으셨죠 여기? 김태호 선생님도 그렇고 저도 그렇고 소영 선생님도 그렇고. 그다음에 이경원 원장님하고 눈의 병원하고 현대성모병원 팀이 같이 하고 있습니다. 그래서 여기서 도착하시자마자 본인 스코피 연습하시고 똑같이 수술하시고 연습하고 그 이제 사진이 많지 않아요. 마지막 날 이제 비행기 타고 가기 전에 아르메니아 시내 구경 같이 하면서 찍은 사진입니다. 이게 2016년도 8월 사진이고요. 마지막으로 저희가 이제 갔던 게 2017년도 12월에 어떤 사진입니다. 이게 그 모스크바를 항상 들렸다 가야 돼요. 아르메니아 가려면요. 모스크바에 그때 폭설이 와가지고 모스크바 공항에서 갇혀가지고 화장실도 못 가고 뭐 그냥 비행기 안에 갇혀가지고 잠깐 밖에만 숨만 쉬고 오라고 그래가지고 열어주고 그래서 왔다 갔다 했던 사진이고요. 이게 거기에서 이제 그때 가셨던 배영원 선생님, 유영철 선생님, 뭐 이상엽 선생님, 이영철 선생님 이렇게 해서 네 분 갖다 줬고 여기서 사진 찍었고, 그다음에 본사에서 마이크 딜론이라고 사장 마지막 날은 이제 자기네가 핸들링하기 어려운 환자들 좀 봐달라고 요청이 와가지고 그래서 거기서 그때 녹내장이랑 다른 질환 있는 환자분들 봤는데 장면 진짜 오래됐어요. 저 뒤에 있는 뭐 야브레이드 이런 거는 보니까는 국가가 웨스트 절민으로 들어가는 제조기에 오래된 제품들이 여기 장면들이 있었고 마지막 날은 봉사활동으로 같이 이렇게 또 봐주시고 맞습니다. 그래서 저희가 보험은 2018년도에 I-Stent 1세대를 받았고요. 그 다음에 2022년도 11월에 인젝트 보험을 받아서 지금까지 와 있습니다. 그래서 앞으로 저희가 오늘 간단하게 소개시켜드릴 거지만 I-Stent Infinite 하고 그 다음에 I-Glaukos 기타 제품들에 대해서 오늘 좀 글렌 아시아 지역 부사장이 말씀드리고 그 다음에 알리스가 저희 임상 관련된 거 하는 친구 여기 있는데 알리스가 하이드로스, 알코올 하이드로스하고 저희하고 이제 비교된 논문들을 보여드리고 그렇게 하겠습니다. 그럼 식사하시면서 얘기 들으시면 되겠습니다. 감사합니다.
Where Glaukos is heading in terms of regarding I-Stent Infinite, one of our newer products just launched in the US, and also some updated data that's just come out regarding some 5-year endothelial cell loss, which we'll go through as well. Almost 8 years, and in ophthalmology for about 26 years. So I know enough to be a little bit dangerous in terms of ophthalmology. My colleague here this evening, Alice Chu, based in Singapore. She's our Director of Market Access for Asia Pacific and also medical marketing. So when you see a lot of the studies coming out of Asia, Alice is involved in those, working with doctors. Procedure codes, it all has to be created. And so, along with our partners at G1, with Sayun and his team, we're helping create and educate and bring these products to market. And what you'll see this evening in some of our newer products, again, they're first of their kinds. And so it's never easy when you're first of its kind. There's a lot of hard work to establish these products. And in combination with societies, with the glaucoma societies, with the ophthalmology societies, working hand in hand around the globe to bring these products to market. So in terms of our overall strategy, we have novel technology platforms, and then commercializing those, as I said. So it's often created in terms of big ideas. And big ideas started with very small ideas, such as the I-Stent Inject back in 1998. And that took 15 years to come to market and commercialise. A product I'll talk about this evening, iDose, again about 15 years from concept to commercialising. So many of these products take many, many years of lots of hard work and lots of clinical work to bring them to market. So last year, this is just some of the highlights of Glaukos. In different markets, we launched products called I-Access, a goniotomy device, I-Prime, Visco canioscopy device, and the I-Stent Infinite, which is what we'll talk about this evening. We moved forward with our iDose TR, so Travoprost product, and we also moved into a new headquarters in California. So if anyone's ever in California, we'd love you to come and have a look at our new headquarters, see our manufacturing as well. It's located halfway between LA and San Diego. We've also moved into the corneal space with a product called iLution for dry eye and presbyopia, and moved into some of the preclinical areas in terms of our retinal pipeline. In this year, we're really continue to develop the MIGS market globally, and starting to move into some new markets around the globe. One in particular, towards the end of this year, will be China, and last year we entered into India as well. So two very big markets, but not without their challenges. As I said, we continue some trials there for I-Stent Infinite and expanding that label, and then that iLution, which I'll talk about as well. So in terms of glaucoma, and I guess that's what we're here to talk about this evening, glaucoma traditionally is treated with topical medications. So one drop, not getting the pressure lowering that you're after, so you add a second drop, or you'll switch out those medications, and continue to add medications. We were talking about SLT, and different surgeons will use SLT at different rates. But really after that, it was filtering surgery and then aqueous shunts was the mainstay. And that treatment algorithm has been used for many, many, many years. But you'll be very well aware, and this is some information from the US, that 90% of patients are non-compliant. It's a huge issue. They don't like taking their drops. The side effects from the drops are very bad. And so, not surprisingly, at 1 year, 50% of patients have dropped out. They've stopped taking their medications. And then they wonder why their disease is progressing. And so this is where this big idea from Glaukos came from. How do we take that non-adherence out of the patient's hands and put it back into the hands of surgeons to manage their glaucoma? So we are calling this interventional glaucoma. And I-Stent was the first of the products, but there's lots of products in our pipeline to intervene early from a surgical point of view to treat that glaucoma, improve patient management, preserve visual function, slow that disease progression, and reduce or eliminate the need for topical medications as well. And then all these products target a 24/7 aspect. So as we know with drugs, there is diurnal variations in a lot of them, but with mixed therapies, such as the I-Stent Inject, you know that if it's working 24/7. And so patients are getting management of their glaucoma very, very well. The third point there, improved patient quality of life, shouldn't be underestimated either. The quality of life aspect of I-Stent Inject, it was the first of the mixed devices to actually look at quality of life. And we did some studies on our initial cohort of patients in our FDA study. And as you might be aware, it's very difficult to show improved quality of life in glaucoma studies. But with I-Stent Inject, we were able to show improved quality of life as well. So we've invested about $400 million since 2018, and many hundreds of millions of dollars before coming to market. So it's about 30% of our global revenue goes back into R&D to bring new products to market. Back in 2015, when I joined, there was 4 public projects in our R&D pipeline. Now we have 14 in our R&D pipeline. So lots of products coming. And you can sort of see here, in terms of the glaucoma, I-Stent and I-Dose, which is our drug-eluting. But we're moving into the retina space with Retina XR, iLution, and iLink is in the cornea there as well. So iLution is an interesting one where it will it'll be in the corneal space and the glaucoma space in terms of drug delivery. I'll talk a little bit about that. So in terms of the glaucoma pipeline, not all of these products will be available in all markets. But I-Stent Inject W, we're familiar with. I-Stent Infinite was launched just late last year in the US. Our I-Dose product, our drug-eluting, probably early next year in the US, and other markets to follow. In some markets, particularly North America, South America, Canada, Australia, New Zealand, we represent Santen for the PreserFlow product. In other markets, in Asia, I think that's still to be determined in terms of what they're going to do. In Europe, Santen represents themselves with PreserFlow. And this is what I mentioned before, a precision goniotomy device and a visco delivery system, icon. In some markets, it's reimbursement driven, particularly the US. They do a lot of goniotomies in combination with I-Stent because of reimbursement. But we'll assess each market in terms of what surgeons believe they need for their patients. But this is just really to show you how we've grown from a product or a family to a family of products. What started with an I-Stent, our first generation. So I-Dose, this is going to be the next, I guess, big revolution in terms of products for our company. For those that haven't seen the product, this minimally invasive device is about 1 millimetre in length. It can be implanted standalone or in combination. We submitted to the FDA just last month and expect to have approval by the end of the year, and then launching in the US next year. This little product with a membrane here, as it says there, it elutes drugs over time, in this case travoprost. So our phase 3 data, the comparison with Timolol is still considered the gold standard in terms of what we have to compare against, even though prostaglandin analogues are more first-line therapy in many markets. But you can see there when we compare our slow-release I-Dose TR compared to Timolol, very good pressure lowering versus that gold standard. In terms of the subjects in this study, 1,150 2 arms. Mean baseline IOP of 24 millimeters of mercury in each study. 81% of the patients had open angle glaucoma and 19% ocular hypertension. As it says there, 67% of slow release subjects were on at least one IOP lowering medication at screening, and 23% had 2 or more. So it's really that sort of general population that you see in terms of your glaucoma practices that are treated. So our phase 2B study, we've measured out to three years. And like with all medications and all, glaucoma patients, the disease will progress. But we're still seeing very well controlled on the same or fewer IOP medications at 3 years. In our phase 3, so this group was about 70, patients. This group close to 1,200 patients. But you can see it's following it very well at 12 months. And we'll continue to follow these patients at 24 months and 36 months. Likewise, in our phase 2B study, we're now following these patients out at 4 and 5 years as well. And we'll release that data as it becomes available. So it's the biggest study that we've done at Glaukos with this many patients. It was our CEO says a Herculean effort to get the company to this stage. In the study, 81% of the slow-release subjects in the phase 3 study were completely free of meds at 12 months. So, you can see one eye dose versus, this is timolol, 2,190 drops over that 12-month or that 3-year period. So you think of patients having to take their drops for that length of time and the side effects, and I'm sure you've seen in your own patients after long-term use of prostaglandins, red, itchy, sunken eyes. It's much better quality of life for patients with one eye dose. In terms of the side effect profiles, obviously with topical prostaglandin analogues, there's that periorbital fat atrophy, there's conjunctival hyperemia, there's hyperchromia, changing iris colour as well in some patients. In the I-Dose group, both the 1 year and the 3 year, very, very low incidence. And in fact, in terms of hyperchromia, so change in iris colour, I think it was only 1 or 2 patients in that 1,200 patients that was tested. So very, very benign and very, very safe for the patients. One of the big questions we're often asked is endothelial cell density. I think after what happened with CyPass, and it's withdrawn from the market because of concerns of endothelial cell loss, we have followed these patients out to 5 years, and you can see the rate of loss from baseline is very similar to the average rate of baseline, the average loss of EC endothelial cells in the standard population. You can see here it says redosing and then a second redose. So this was an exchange process where the surgeon had to go back in, obtain a second eye dose and take the first one out. And so we were also measuring, was there a lot of endothelial cell loss in those patients during that procedure. And again, you can sort of see that there was very, very low rate of loss. The interesting thing here is that FDA considers anything greater than 30% loss as severe. And in this study, no patient in this study group had severe loss of endothelial cell loss of greater than 30%, which was very, very pleasing. So it's a small device. We were talking before, where do we see this going? It's obviously, it's got the efficacy there, it's got a good safety profile, exchanging is very easy. The question would be, can it be done in office? And in the States, in the US, when we did this study, we actually did it as an in-office, minor ops room to show that it could be done. But again, each country can be different, whether or not patients need to take it into theatre, and some of that will be driven by reimbursement as well. So this is our pipeline of products for glaucoma, and you can see there's a lot coming. We wish everything could come and we could show that to you and sell it to you today. These things do take time, but we're working on a lot. In terms of I-Dose, we're already working on our next generation. So we call this I-Dose T-Rex. It's the same length, but wider, so it can hold twice the drug. So if in I-Dose TR we get 3 years, can we get 4, 5 years plus for this product? We're also working on a ROCK inhibitor. That's in preclinical at the moment. And again, ROCK inhibitors on the cornea have a lot of side effects. So if we can bypass the cornea, that's a good thing, and deliver ROCK inhibitors. And then there's a number of other compounds which aren't publicly disclosed at the moment we're working on. iLution is our proprietary cream. We're working on delivering glaucoma medications through a cream-based formulation, and that's in preclinical now, actually. So this is the iLution platform. So iLution is a cream-based formulation that is rubbed onto the eyelid. One of the products which is in phase 2 at the moment is this dry eye product. So it stimulates the meibomian glands to help generate aqueous, and that's proven very successful so far. We're also working on presbyopia, so like a pilocarpine drop, and then Demodex blepharitis in preclinical, and then travoprost there as well. So So again, trying to provide solutions for you and your patients who don't like using drops, or maybe they have arthritis or difficulty holding bottles, they can use this cream. The other area we're moving into is retina as well. You can see some of these preclinical programs. So a multi-kinase inhibitor, triamcinolone for AMD, DME, and RVO. So retinal vein occlusion, macular degeneration. In terms of patients having to come back for injections, every 4 to 6 or 8 weeks, we believe the product we have, at least in the rabbit models that we've been doing this in, is lasting 6 to 8 months. So very exciting, very early in terms of its development, but very exciting as well. I mentioned our new manufacturing. So this is some of the manufacturing locations, but it's a dedicated pharmaceutical manufacturing facility for iDose and some of our other products. When I joined in 2015, there was 65 commercial personnel. This year there's over 275, so we're growing significantly. And we can only grow from your support. Your support helps feed this machine to bring new products as well. So again, thank you for your support to help us bring more products to market. So this is our full pipeline now, and you can sort of see from what was a very small company is growing into something much larger. So I look forward to coming back regular to Korea and updating you in terms of where we're at with some of these products. This evening we wanted to talk about I-Stent Infinite, because I know there's a number of I-Stent users here. I-Stent Infinite, not an infinite number of I-Stents, but an infinite number of clicks on the device. I actually have, so you can actually sort of feel it, a couple here as well. So after we finish our presentations, I'll hand this around so you can have a look and feel of the device as well. The nice thing about it is the stent is the same. If you're familiar with I-Stent Inject, it's the same. But in terms of I-Stent Infinite, 3 of those devices have been preloaded for you. But in terms of the overall dimensions, 360 micron flange, and overall length of 360 microns as well. What is different is the injector. So in terms of the injector, this little button is the stent delivery button. This purple one is, we call it the singulator. And the easiest way to think about it is a little bit like a shotgun. As you pull this back, it reloads the next stent. When the device comes to you, it's already loaded and set for the first implantation. So there's no need to pull this device back. Basically, when it's handed to you, the first stent is ready to go. So you press this black button, the stent will be delivered. What is a little bit different is to allow movement into a wider area of the angle. There's an angulation here. So again, you won't have to tilt the microscope as much, because that will enable you to implant. There is also what we call this worm. This little device here helps retract the insertion sleeve, and then at the tip here, that actually sits up against your incision to stop the egress or viscoelastic coming out as well. So you can see here the trocar, very similar to the I-Stent Inject, and that little window, so you can see the devices. Once you have implanted the first one, you will basically pull that trigger back, and that reloads the next stent into place. But I'll hand that out afterwards. So you can see with this technology, by keeping it at least 2 to 3 clock hours apart, you can span about 240 degrees of outflow coverage in the eye. We were talking about Alex Quang just earlier, so this is some of his images showing 3-stent precision placement and that aqueous angiography of showing outflow being created. So that's the device. What I thought we'd do now is invite Alex to come up and talk about, actually, before I do, 2 to 3 clock hours with that sort of backhand, we recommend coming out of the eye, moving your chair, repositioning, and then coming into that third stent. Just so you have that on face or direct view of the trabecular meshwork, and so there's less risk of trocar bias. And that's one of the reasons why we've angled the insertion tube to allow that access as well. So you can see the surgery is very, very similar to what you're experienced with. The difference being a new injector and unlimited click. So if you did have an under-implantation, you can either re-thread inside the eye, or you can take that stent out and you can re-thread outside the eye as well. But unlimited clicks. Okay, so prior to the launch in the US, this surgeon is probably familiar to you, Dr. Ahmed, speaks a lot on mixed devices, but his point in this with 8 other KOLs in the US was the current treatment algorithm is in crisis. You know, we need to consider intervening earlier in the disease and intervening surgically and taking that risk of non-compliance and side effects with drops out of patients' hands. And so there's this mindset shift to interventional glaucoma. And if I think back to 8-10 years ago, how many people globally were using a mixed device? It was a lot less than it is today. And so there is a change in the mindset in terms of how we are treating patients. And I thank you for your time and your support. And I will pass on to Alice to talk about some of the clinical data with I-Stent Infinite as well. Thank you. And we'll take questions at the end.
Published. This was done for our FDA indication. So what's different about this study population versus I-Stent and I-Stent Inject is most of the studies in I-Stent and I-Stent Inject are in mild to moderate, right? So it depends on the glaucoma severity. In this case, the study population has to do with treatment burden. So these are uncontrolled OAG patients, right, who are either medical refractory, so maximum tolerated, or have failed filtration or cilioablative surgery. Okay, so glaucoma severity was not inclusion criteria. It has to do with treatment burden. Okay, so there were 72 eyes. This is multi-centered. Okay? And I would say majority of the patients were pseudophakic. And there were 2 endpoints, effectiveness endpoints. One is the proportion of eyes achieving at least 20% diurnal IOP reduction from baseline on same or fewer glaucoma medication classes. Okay. The second endpoint has to do with mean change in IOP reduction. Right, so this is the baseline characteristics. See, 92% are already pseudophakic. 85% have failed filtration surgery already. Okay, and you can look at in terms of glaucoma severity, it had about 43% were mild to moderate, and the rest were, advanced to severe. This is the mean diurnal IOP. The mean meds were about 3, okay? And you could see that the medication burden ranged also from 1 to 4. MTMT means at least on 4 medications. Now, the cohort consists of everybody, the 72 eyes. They also did a sub-analysis in eyes that were MTMT only, which we had 11, and those that had surgical failure. And you could see that overall, about 76% of the eyes achieved at least a 20% IOP reduction on same or fewer meds. Okay? And in terms of the second effectiveness endpoint, the average IOP reduction is about 6. And you can see that in MTMT, the IOP reduction is, slightly is greater than those with surgical failure, which kind of makes sense. Now, in those who are responders, right, this is the percentage of eyes that can achieve these target percentage reductions. Okay, so it's 82% at 20%, 53% overall, achieving 30%, and then 21% in achieving 40% reduction. And don't forget that these are difficult to treat eyes. And so how about in achieving target mean IOP? You had about 91% under 21, about 74% 18, and 36% at 15 and below. Now in terms of medications, right, 93% of eyes did not have more medications than baseline. And you can see that about half of them had medication reductions, and the other half remained the same after 1 year. Now, I-Stent Inject Infinite, you're going to compare it to blood-forming implants or procedures. It is very safe. Okay, so if you look at the number of additional glaucoma interventions, there were only 4.2. It was 2% surgeries, and it had nothing to do with the implant itself. So, in terms of the evidence here, you could see that in these difficult to treat populations, right, we had a high proportion of eyes that managed to get at least a 20% IOP reduction. Right? And you also see that 93% of eyes did not have an increase in medications from baseline, and there were minimal post-operative interventions. So this is something to think about to add into your treatment algorithm in perhaps from patients who are on 1 drops all the way to those who are surgical refractory. Okay, so that's the evidence for I-Stent Infinite. Now I want to shift to what you're using right now, I-Stent Inject. So we recently published, or I published our 5-year follow-up data on our I-Stent Inject pivotal study, our RCT. This 5-year, it's not this is an extension study. Okay, so patients after 2 years were asked, would you like to continue on for another 3 years? And what we emphasized here, what we focused on here is endothelial cell density. So what I put here is the results. So one of the endpoints was, 0% of eyes had clinically relevant complications associated with I-Stent Inject itself. Okay, 0. And when we're talking about ECDs, there was no difference between groups in the mean ECD at year 5 or the percentage change in endothelial cell loss at year 5 versus baseline between the treatment groups. So I-Stent Inject with cataract surgery versus cataract surgery only. In addition, they measured the analyzed rate of endothelial cell loss from month 3 to month 60. Again, no statistically significant difference between the implant group and the control group. And lastly, and most importantly, is that there were no differences in the proportion of eyes that had severe endothelial cell loss at year 5, and actually at every time point. Okay, so based on this study, if anyone went to AAO, they used that data, and they wanted to also analyze the data from the Horizon, so Hydrus' 5-year results, and also CyPass's 5-year results. This presentation here focuses on endothelial cell density only as well. Okay. So just to tell you that the Horizon study is a continuation of the RCT, whereas an I-Stent Inject and CyPass is an extension study. Okay, and you can see that at baseline, there was no difference between the groups in the implant and cataract surgery only, just to show you that in the studies, at least there's no bias at the start of the study. And what this study measured is what is the mean ECD at these particular time points, but what they really want to focus on is at month 60. Because if you read the Horizon study, they do not present clearly on what is the year 5 endothelial cell difference between the treatment group and the control group. They also do not report the overall change in endothelial cell loss. So this study does report it. Okay? And they also looked at the proportion of patients with greater than 30% endothelial cell loss. So if you were to plot the mean ECD from all 3 studies on one graph, if you pay attention to the orange, that is the I-Stent Inject plus cataract surgery versus cataract surgery only, and you could see that it superimposes on top of each other. You cannot distinguish between the two. Whereas if you look at SidePass, this is the cataract surgery only, and this is the SidePass group, right? This is, we all know that it accelerated, right, around 48 months and on. If you look at Hydrus, right, you have a endothelial cell loss up to month 3. This is probably because of the procedure, right? And then this is the Hydrus' control group, and this is the Hydrus group. This is statistically significantly different, and so is SidePass, but not I-Stent Inject. Then you want to focus on the percentage of eyes with severe endothelial cell loss at year 5. This is not statistically significant. This is about, what, a 2-fold? And here you have SidePasses. Okay, so this is something for surgeons to consider when they're evaluating patients, right? You got to consider, the age, right? The progression. That, endothelial cell loss does occur, and it probably does depend on really your procedure skills. In some cases, like SidePass, it has to do with the implant itself. Okay, so the conclusions were that, among the 3 implants, when you're just comparing within their control group, their respective control group, I-Stent Inject is the only one that had no difference, right, with their control group. And so that's why we should start thinking about endothelial cell health in your patients. This study will be published. It was submitted into a journal and should be published in about maybe a month later. Okay. Thanks. Any questions?
There that may be of interest. And I think just to close off on Alice's presentation, is that Glaukos, we're all about safety and being minimally invasive. And so that's why we did this extension study for I-Stent Inject. It wasn't a requirement by the FDA to do this study, but we felt it was important to do this. Where some of the other devices that Alice mentioned, they were required by the FDA because of concerns, which obviously in some of the products was justified, since been withdrawn from the market. But yeah, any comments, any questions?
And for you, do you think it's going to be safe in the MRI scanning when you use the I-Dose T-Rex?
Yes.
Which is big, right?
Yeah. So it's all to do with the how much metal is in there, and I know the I-Dose TR is safe for MRI. I haven't seen whether or not T-Rex is or not, but I would say we are making sure that it is safe for MRI. Much like the first generation and our I-Stent Inject as well are all safe. Yeah. Good question.
And for Alice, do you think the Hydros is going to be withdrawn in the future?
Well, okay, here's the thing. CyPass was withdrawn because it is the implant itself, right, that was causing the endothelial cell loss. Because the rate of change, you notice after the procedure, right, after month 3, let's just say, you see this kink, so it's accelerated. Whereas Hydrus, it's not accelerated, but maybe it has to do with the implantation itself that caused a quite difference, right? So I don't know. I don't. In their IFU, I think there was maybe 1 or 2, or maybe 6 eyes that did have a corneal edema. I have to look at their eyes. Yeah, but I don't know.
So there's a chance.
I don't know.
No.
I don't know. Because it's not the implant itself, right? So I think it's probably surgeon skills that need to.
Similar to CyPass, a lot of surgeons who did use CyPass, they said in their hands they were implanting it correctly, making sure it was well seated, only so many of those retention rings were visible. And so they thought, well, if the CyPass was still available, they would still use it. And I hear similar comments from surgeons with Hydrus saying, well, in my hands, I always make sure it's implanted correctly, but that device can migrate as well. And so sometimes I've had surgeons comment that a patient's been referred from somewhere else, and there's a good 1.5 millimeters sitting in the AC because the device hasn't been implanted correctly or it's migrated as well. So there's a concern, and all that fluid dynamics of the aqueous movement within the eye as well can lead to these issues as well.
Yeah, even though they say they're safe, but there's always a chance to make some wrinkling to the eye
Yeah.
by their hands.
Yes.
Yeah.
Yeah.
And it's bigger. And my concern is that. And the last question for 윤 대표님께 그 혹시 이 하이드로스가 나오면 아이스텐트랑 같이 넣어도 되게 좀 해주실 수 있을까요? 한 번에.
그럼요. 그건 저희가 그렇게 해야죠. 그거는 이제 녹내장 하시는 분도 도와주죠. 그게 된다라는 거를 외국의 사례도 저희가 좀 많이 식약처에 제출하거든요. 평원에. 근데 이제 이게 같이 될 수 있게 하는 녹내장 학회에서도 좀 도움을 주고.
Well, the worm, so as you go into your incision, that automatically retracts the sleeve back, exposing to the trocar at the end. So you would fire, as I said, the stents on there, and then once you're happy with the position, you load that back, and you can fire again. Reload. So the first, when you get it, there's already a stent loaded, so the first press that will fire, then you'll click, that will bring the next one into place. Yeah, very similar. Yeah, you can see that angulation. And at the end of that insertion tube is designed to sort of sit against your incision.